the Wenlock room. We've got three presentations this afternoon, so won't waste any time. We'll get straight on with the first presentation, which is Sarah Lucas from the Strategy Unit, who is going to present to you about using causal impact analysis to measure the impacts of changing from multi-bed to single-bed hospital rooms.
Thank you. So this is work that I've done at the Strategy Unit alongside Andy Hood and Anya Ferguson. So there has been this kind of move in the UK and globally towards having single-bed inpatient rooms rather than the traditional multi-bed bays. And the New Hospitals Programme has advocated for hospitals to have single-bedded rooms. But there's still quite a lot of uncertainty about what the impacts of this kind of change would be. And there was this starting assumption put forward that single bedrooms would reduce length of stay by about 12%. But actually the evidence base in the literature for this is quite mixed. So there was this need to try and quantify what the potential impacts of moving to single bedroom hospitals would be. So we had some sort of evidence to inform the modelling and the business cases for new hospital developments. So this is work that was done as part of the New Hospitals Programme. So it was a retrospective study. We investigated 7 hospitals in England that have switched either entirely or partially to single bedrooms in the last 14 years. So there are 4 general acute hospitals and then 3 specialist providers. And so we used these as kind of a natural experiment to see what happened to various metrics at the point when they switched to single bedrooms. So we looked at a whole host of different measures, and they kind of broadly fall into 3 key domains. So we looked at productivity and efficiency measures such as length of stay, waiting time, emergency readmissions, bed occupancy and cleaning costs. We also looked at some health and safety measures, so in-hospital deaths, in-hospital falls and injuries, and hospital-acquired C. difficile. And we also looked at staff and patient experience. So for patient experience, we used the inpatient friends and family test. And then for staff, we looked at staff survey results, staff turnover, and staff sickness absences as well. And I should kind of caveat some of this at the beginning by saying there are some data issues with this. So some of what we've used are obviously kind of proxy measures, and so there's a question over the specificity and the sensitivity of some of the measures. Some of the data is also only available at provider level rather than at site level. So where you've got providers with multiple sites and only one site has switched, obviously the effects you see of a switch might be diluted by the other sites. Some of the measures are only available quarterly or annually. There's some issues with COVID-19 for a few of the sites. And then there's a lot of the data's limited historically. It doesn't go back far enough. There's some gaps and anomalies in the time series and changes in providers and sites over time. So all this to say that we haven't been able to measure all of these variables for every single hospital, but we've done the best that we can with the data that is available. So the method that we've used is causal impact analysis. So this is a relatively new technique, and it was developed at Google by Broderson et al. And basically it uses a Bayesian structural time series model. So what it does is it identifies historical relationships, in this case between multiple control sites and our study site of interest. And then it uses those relationships to estimate what the expected outcome would be at our study site if no change had occurred. So on the graph, on the top panel, it's the kind of yellowy coloured line. And then what it does is it quantifies any change that you see at the study site by comparing it to those expected results. And that's what the bottom two panels of the figure are showing. The point effect at any point in time, and also the cumulative effect over time in the outcome period. And the way that we've done this is we've used the market matching package in R. So it's a wrapper package, and it combines the DTW package, which we've used to select our controls, and the causal impact package itself. In terms of our workflow, we've used a two-step control selection process. So the first step was for each of our study hospitals to find a pool of control hospitals that were kind of well matched. And we matched these based on the hospital type, so a general acute or the same type of specialist site, on hospital size, on case mix, where we used patient age and also the ratio of elective to non-elective activity, and the percentage of single bedrooms prior to the switch. So once we had that pool of control sites, we then had a second step, and that's where we used this DTW package, which performs dynamic time warping. Basically, that's a way to select control sites that show similar historic trends to the study site of interest. So it will select you up to 5 control sites. And you have to do that, obviously, for each hospital and each measure. And then for each hospital and each measure, we generated a causal impact model. And the package gives you various outputs, but what I'm going to show you today and what we've kind of used is the mean relative effect size in the outcome period, because that allows us to make comparisons between hospitals and also to perform some meta-analyses as well. So obviously one of the things we were really interested to look at was mean length of stay. So these are our results, and each dot represents one of the hospitals, so we only had data for 6 of the hospitals. But what you can see, there's a lot of variability in what happens to length of stay following a switch to single bedrooms. So at 3 sites, they saw a reduction in length of stay. At 1 site, there was an increase in length of stay. If you then look at the 4 general acute hospitals and you do a meta-analysis for those, what we actually found was a non-significant 8% reduction in length of stay. So taking that and looking at the variability of all 6 sites overall, we clearly don't see that significant 12% that was kind of proposed. And one other kind of interesting result that I wanted to share was around the staff survey. So what we did is we looked at the question in the staff survey, which asks whether staff would recommend their trust as a place to work. And we looked at the percentage of staff that gave a positive response to that question. Again, you can see we've only got data for 6 of the hospitals. And again, it's very variable. So significant decrease in scores at 2 hospitals, a significant increase at 1, and 3 others it remained unchanged. And again, when we did a meta-analysis of the 3 general acute hospitals that we had data for, this time we actually found a significant 15% reduction in the proportion of staff that would recommend their trust as a place to work following a switch to single bedrooms. So this is basically giving you a summary of all our results. So where things are shaded in grey, basically that means we've got missing data, or in a few cases we were unable to actually just fit a model. We had the data, but we couldn't fit the model. And then we've colour-coded, so where we've coloured it green, we consider it a positive effect. Where it's red, a negative effect. So you can see when you look across each of the different variables that we've looked at, for all of them, the results are quite variable. And there's also variability between the different hospitals. So you'll see the hospitals going down. If you look at Hospital G, you can see that actually, following their switch to single bedrooms, they've generally seen positive impacts. But actually, when you look at Hospital B, that hospital, the results have been a bit more mixed. And so this is just another summary looking at the effects of the meta-analyses for general acute hospitals. So obviously the numbers are very small here. There was only 4 general acute hospitals in the first place. But what you can see from the meta-analyses is, in terms of the productivity and efficiency measures and the health and safety measures, and also patient experience, there was no significant changes. But following a switch to single bedrooms, as I've shown you, we saw a significant decrease in staff survey scores, but we also saw a significant increase in staff sickness. And that was most apparent in that first year following the switch. So finally, it's been difficult to draw kind of firm conclusions from this data because our findings are very inconsistent, both within indicators and overall between hospitals. So it looks like simply by switching to a single bedroom hospital, you're not going to automatically see any positive effects. But we think that there might be some positive effects for some hospitals of switching to single bedrooms, but it's likely to depend on getting the right hospital design, and the other factors that are associated with implementing that change likely need to be right in order to see any kind of positive effect. And so it's clear that more work is needed really to understand what factors might make a switch to single bedrooms more successful. But one thing that did kind of come out from our data is that a switch to single bedrooms seems to negatively impact staff. So it's certainly going to be important to better understand the experiences of staff and consider possible mitigating factors. Thank you for listening. I'm happy to take any questions.
Thank you, Sarah. We've had one or two questions come through, but I'll just ask in the room. We've probably got time maybe for one or two questions. The next talks will be starting in other rooms in about 4 minutes' time. So is there anyone in the room that would like to ask a question? Just hang on, I'll run over.
Thank you. It was so interesting, and I'm particularly interested in how you chose your control groups. So I have two sort of linked questions. The first is, you had a list of metrics, same case mix, etc. How did you decide on that list, and how did you know that there wasn't something, I don't know, one had changed the restaurant meal plan and the other one hadn't, that might have impacted the outcomes? And then, sort of linked, what did you do if you couldn't find a suitable control for a hospital?
Okay, so part of how we kind of came to those control factor, those matching variables, was kind of based on also making sure that we had enough controls. So we had like a long list of things we would have ideally matched on, which was longer than that. But obviously we had to kind of cut it back because otherwise, especially for the specialist sites, we wouldn't have got enough controls in the first place. So to some extent, that kind of limited what we could look at. And yeah, obviously that is another big issue with the work, is that we don't know what else happened at the same time that they switched. So yeah, example, yeah, it could be that, you know, there's a new restaurant. It could be that some of the services have moved as well. If it's a multi-site provider, some at the time of the switch, some services might have moved as well. So yeah, it is a lot more complicated, and we kind of need a bit more context to be able to fully understand the results.
Thank you. Do move rooms if you need to at this point. There's a couple of minutes before the next sessions will be starting, but we will just take another question while you're doing that, as there have been quite a few that have come through. Further question, Sarah, that we've received is there any way to understand the ability of nurses to monitor rooms rather than bays?
So there's kind of been some stuff in the literature about this already, and so yeah, we think that that's what's kind of might be driving that those kind of staffing issues, is to do with the visibility of patients and things like that. And we know that some of those hospitals had different designs, and we know some of them where perhaps the staff experience was more negative were the ones where the patient visibility was actually more difficult, just from conversations that we've had.
Thank you. Right, we will stop the questions there. There have been some further questions, but we'll get those to you for responses later, Sarah. Thank you very much.